Jasmine here. So I'm starting this little video series I like to call Parkinson's 101, where I teach you interesting things about Parkinson's disease more from a scientific aspect. And so what I'm doing today is my first video. Let's talk Parkinson's meds. So I'm kind of going to go over what the different meds are we take, why we take them, how they work, and then a little bit about meds that you shouldn't take if you have Parkinson's because they can be incredibly dangerous. So I'm going to start here with Levodopa. Also, excuse my poorly drawn doodlings on these, but Levodopa, I drew a little crown on it because it really is the gold standard of medication. So Levodopa is the precursor to dopamine in your brain. So the thing that's really important to understand here is something called peripheral dopamine and central nervous system dopamine. So dopamine, along with a couple other neurotransmitters, also work as hormones in our body if they're peripheral. So that means that they cannot cross the blood-brain barrier. So what's really important to understand is that with Parkinson's, the dopamine loss is in your brain, not in your peripheral nervous system. So you have dopamine as usual in your peripheral nervous system. So if you were to just take dopamine, you wouldn't get it up in your brain because it can't cross into your brain, where you really need the extra dopamine. So we take Levodopa, which is the precursor to dopamine. And that's important because Levodopa can cross the blood-brain barrier, and so can actually get up into your nervous system. So what's important to remember is that if you look at your Cinemet bottle, you take, Cinemet being the name brand of Levodopa, you take carbidopa levodopa. So carbidopa is something called the dopa decarboxylase inhibitor. And so what carbidopa does in your body is it keeps your body, your peripheral nervous system wants to turn levodopa into dopamine right away. But dopa decarboxylase is an enzyme that does that. So you have that up in your brain too. It turns levodopa into dopamine. So the carbidopa inhibits the dopa decarboxylase in your peripheral nervous system and keeps you from using up the levodopa before it gets to your brain where it's important, where it's needed, and where the medicine is supposed to act. So that's very important. So that's how your levodopa works. Now this is the gold standard of medication, and it's very important, but it does also have a couple of side effects to it. The biggest of the side effect being dyskinesia, which is my next point here. So L-Dopa induced dyskinesia. Levodopa induced dyskinesia is one of the major problems that people who have Parkinson's face, because levodopa induced dyskinesia can actually be even worse than the disease itself at times. So what dyskinesia feels like is kind of like your body flailing. You'll find parts of your body just uncontrollably moving. If you've ever seen a video of Michael J. Fox, sort of in the height of his Parkinson's, really what is happening there is he's having levodopa-induced dyskinesia, where he's just moving around and he can't even stay still. And so that's not the Parkinson's, that's the reaction to the Parkinson's medication. And so if you don't take the Parkinson's medication, you might be frozen or stiff and trembling, or you might have severe rigidity and just such slowness of movement that you can barely move. But you trade that off for the side effect of dyskinesia. So dyskinesia usually happens about 5 to 10 years after you initially start levodopa treatment. For some of us, that's a little bit earlier. For me personally, it was 2 years. And typically, the younger you are, the earlier you get dyskinesia, which is unfortunate. But that sort of starts this whole great Cinemet debate that doctors have, is when to put somebody on Cinemet. On one hand, it's the medication that works better than any other medication for Parkinson's. It relieves the symptoms the best. But on the other hand, you have that the earlier you start it, the earlier you're going to get dyskinesia, because it's kind of an inevitable thing. So, I mean, personally, I do believe that I would rather have the relief earlier and then deal with things later, but not everyone agrees. So that's important. But the treatment for that, there's a couple different treatments. Some anti-seizure drugs sort of show promise to have treatment in the future for dyskinesia. Some say that nicotine may help, or then there's always deep brain stimulation, which if you looked at my channel, you know I'm personally a big fan of. It's definitely saved me from dyskinesia. But the medication management, which I'm going to talk here, is called Amantadine. That brings me to Amantadine, or Symmetril, as is the name brand. So Amantadine is interesting. It's got an interesting history here. So back in the 90s, I believe it was the 90s, it was used as a flu medication. And so what happens is they give it for the flu, and some of these older people who have Parkinson's, elderly Parkinson's patients, started noticing an improvement in their dyskinesia and in their Parkinson's symptoms in general. So they started investigating Amantadine as an anti-Parkinson's drug, and it was shown to help dyskinesia. It's something called an NMDA-type glutamate receptor antagonist. how that works isn't so important for this, but basically it increases the dopamine that's being influxed into your nervous system and keeps the dopamine from being uptaken back up. It's also got a bit of an anticholinergic effect. So amantadine is an anticholinergic effect, blocks acetylcholine, which I'll get to in a bit. But amantadine does have some side effects. For me personally, it messed my blood pressure a lot. For a lot of people, they get different edemas or different other problems with amantadine. And amantadine doesn't always work for everybody. Some people don't have any improvement in their dyskinesia with amantadine, but it can be an effective tool, and it's definitely worth trying if you have dyskinesia from levodopa. So what I was saying about it being also an anticholinergic, I'm going to go into a medicine called artane. I think artane's trihexyphenidyl is the other name of artane. And artane is an anticholinergic. Now, there's a couple of different anticholinergics, Congentin being one of them, but artane is probably the most common that you'll find as an anticholinergic. Anticholinergics are good for motor symptoms. So acetylcholine initiates muscle movement. So your motor symptoms being like tremors or dystonia, artane can be particularly helpful for. Yeah, definitely the more motor symptoms there. But it's just one more tool we have. It's not the most used, but if you do have very bad motor symptoms, artane can be helpful. So now I'm going to talk a little bit about inhibition. So inhibition is a very, very important tool for the management of Parkinson's disease, and you're likely to come across this or have it be recommended to you. So I'm going to talk a little bit how that works. So dopamine is what we've been talking about. The big problem with Parkinson's being you lack dopamine in your brain because your dopaminergic neurons have died. So you've got dopamine in your system, and dopamine is broken down by two important enzymes. So you've got your MAOB enzyme and your COMT enzyme. Now, that breaks it down into products that are no longer usable. They're essentially waste products of dopamine. So now, to keep dopamine in your system for longer, the way the medicines I'm going to talk about works is by blocking the action of these two enzymes so that dopamine stays in your system longer because it's not being broken down. So one of the most important things that this does is lengthen the amount of time that dopamine stays in your system. So what it will do is keep the dopamine in your system longer and keep you from having these horrible fluctuations, which I'll talk about in a little bit. So the first and probably the most important being MAOB inhibition. So these are your drugs is selegiline and Azilect. Azilect is a newer and just it's generally regarded as better. You take it at a lower dose than selegiline. Amantadine really helps with the motor fluctuations. So the motor fluctuations, the problem with that is you take Sinemet, okay, and your body uses it up. And so most people who are neurotypical have a very steady level of dopamine. So dopamine lasts in their system for a long time. The problem with having Parkinson's is you're introducing the synthetic dopamine, and then you're having this sort of crash off when your dopamine wears off. So you're having your dopa levels kind of go up and down and up and down. Why that's a problem is because sometimes the fluctuations can be worse than the low levels in general, as far as things like some of the really severe symptoms go. The fluctuations can just be awful. And so Azilect and selegiline really keep things level between dosages. That can be huge as far as quality of life. The problem with Azilect is it interacts with like 900 different medications. So that's a problem. If you're on Azilect, you've got to be very careful, be really active in talking to your pharmacist and your neurologist about what you can and can't take with Azilect, and just being very aware of that so you make sure you don't have any severe problems with Azilect, because it can definitely cause some very severe interactions as well. The one thing about these medications is because dopamine's in your system for longer, it can make dyskinesias worse. So that is the very little caveat about that. And so then I want to talk about COMT inhibitors. The one thing about this one is, so Azilect is actually now being used in the initial medical treatment. If you catch your Parkinson's early, you can take that before Sinemet, and that can really sort of increase the time that you're doing all right before you need Sinemet. It can work on its own. COMT inhibitors are always paired with Sinemet, and they're paired with Sinemet to make that Sinemet last longer, to prolong that effect. And so there's actually a medicine called Stalevo, which is carbidopa, levodopa, which we talked about before, that Sinemet. So carbidopa, levodopa, plus the Comtan, or entacapone is its other name. So plus those three, and it's in one pill instead of taking two pills. And then there's also a COMT inhibitor called Tasmar, which is sort of the last choice drug. If you're on it, you have to be very careful of your liver functions and get constant liver tests, frequent liver tests to make sure it's not messing with your liver, because it works on a more global scale in your body, and it can be dangerous. That is, if everything else has failed and med management fails, then they'll try Tasmar. So my next topic after inhibition is dopa agonism. Dopa agonism, like Azlect, is a very important thing, especially in early management of PD. Because before Sinemet, they might try you on a dopa agonist to see if you can just hold off for a little bit if you're doing all right on a dopa agonist. Now, dopa agonists work by kind of mimicking the way dopamine works. It sort of tricks your body into thinking there's dopamine there by activating the receptors that you would, if that dopamine would act on. So by activating those receptors and sending the signals down, you're kind of bypassing the need for dopamine. And so I only have 4 listed here I'm going to talk about. There are a lot of agonists, and I'm not going to go into all of them because there's a lot. But these are sort of the most commonly prescribed that I'm going to talk about here. So one of the most important that's come out of recent medical history is apomorphine or Apoquin. These are injectable medications, and these are very important for off days. So if you're having an off day, which most Parkinson's patients know, an off day being your medicines just aren't working, nothing's working. I've had a couple off days where I've ended up in the hospital just because you can't move or talk or do anything, and things just get so bad that you need some sort of medical intervention. Apoquin's a very important tool because patients can take this home and just do an injectable medication, and it basically gives you a boost until your next dose. It sort of starts up things again by activating those dopamine receptors. So Apoquin is a very important tool if you're having frequent off days to have in your arsenal, and you can take injections up to 5 times a day. The other important one is Nupro patch, which I think I have stuck to my hip. Nupro patch is an agonist that is, it's a patch that you put on your body, and it does transdermal introduction of the medication. So you'll be getting a constant stream of medication through the transdermal patch. And so that's an important new advancement too. It's new, it hasn't even been generic yet. It won't be generic till 2019. So you've got a very new medication they're trying out for a new delivery system, and it's important to try different delivery systems, especially when others fail. The next 2 are Mirapex and Requip, and they are pills. They're very commonly prescribed. The one big side effect to watch out for with Mirapex and Requip are the side effects of compulsive gambling and other dangerous compulsions. It can cause some very compulsive behaviors to happen, so that's just something to be very aware of if you're starting Mirapex or Requip. If you find yourself having those compulsive behaviors, to talk to your neurologist and stop medication, because that can be very very dangerous. So those are your agonists, and like I said, there's plenty more. There's like 10 more that are less commonly prescribed, but these are the ones you're most likely to see and hear about from your neurologist. And so now that those are kind of the main drugs that I've gone through, I'm going to kind of go into some other drugs that are just sort of coming out or less common, and that are also very interesting. So next thing I'm going to talk about is Droxidopa. Droxidopa is sort of like the Levodopa for norepinephrine. So norepinephrine is called the redheaded stepchild of Parkinson's research. And that's because they're just finally starting to realize that it's not just the center of your brain, the substantia nigra, that's having problems. It's also a part called the locus coeruleus, which is what controls the central nervous system's norepinephrine. Why that's a problem is because they're finding that Parkinson's patients have also deterioration of that part of their brain, and they're having less central nervous system norepinephrine. And norepinephrine plays a huge part in this whole autonomic dysfunction thing that a lot of Parkinson's patients are reporting. And so that's becoming more and more known. And so what this is currently approved for on the market is for neurogenic orthostatic hypotension. And so that's where when you stand up, your blood pressure drops because you no longer have the mechanism to regulate adjusting your body to the change in position. And so that can be incredibly damaging for people with PD because it decreases your quality of life dramatically. You stand up and you pass out. I mean, it's really hard to manage and it's hard to deal with. And so this is one of the first medications that's being introduced by basically allowing your body to replace the norepinephrine lost. So the next couple medicines I'm going to talk about are called Newplaza and Exelon. And why these are important is because these are sort of less known parts of PD. Typically that affect the elderly PD patients. Younger PD patients are very unlikely to experience these effects. But there's something called Parkinson's psychosis and Parkinson's dementia. So like I said, not everybody gets it, but these medications are very important for those who do. Especially since these two symptoms are considered intractable, meaning that they're not responsive to traditional medicines that would affect somebody who didn't have Parkinson's who had psychosis, or somebody who didn't have Parkinson's who had dementia. Not that there's really a good medicine for dementia at all, but these two medicines are specifically for Parkinson's patients with this, because the Parkinson's brain is different than the brain of other diseases, of people with other diseases. And so these two medicines are incredibly important, and they're very much a step in the right direction from the traditional course of just treating the movement symptoms and not looking at the bigger picture of the Parkinson's brain. And so another thing I want to going back to levodopa, it kind of always goes back to levodopa, or what I call the new kids on the block, and I'm not sorry for that reference. So the new kids on the block being Duopa and Reteri. So Reteri is an interesting pill. It is essentially the same formulation as Sinemet. It's carbidopa, levodopa. There are two types of Sinemet. There is extended release or CR, controlled release Sinemet, which essentially you take it and it's like a controlled release. It releases a little bit here and there by a special coating around the pill. And then there's regular Sinemet, immediate action Sinemet. You take it and it goes into your system. It's like a big boost. The problem with this is people take the boost and they need the boost because you need the levodopa. But people also like the CR because it is sort of a slow release, and that's important too, to have that slow release. But this medicine essentially combines both of them into one. Sorry, my pump is giving me water. But anyways, the Duopa pump. Duopa pump is surgically implanted, kind of like my J-tube that feeds me and gives me water. The Duopa pump is a surgically implanted, essentially J-tube. And so the Sinemet is in this gel, or the levodopa rather, I shouldn't say Sinemet because it's the brain name, but the levodopa is in this gel, and it sort of essentially coats your intestines with this gel, and you run it for 16 hours, and kind of like my pump, you put it in a backpack or a fanny pack, and it's a pump about a little bigger than this note card. And so that essentially gives you this consistent stream of levodopa, so you don't have that wearing off effect. It's also helpful for patients whose stomachs may not be working as well anymore, and so you don't get your medicine as well. And it's kind of lately, it's been sort of like you either have DBS or you get Duopa when you get to the advanced stages, but there are a couple of times when people have both. So, now I'm going to talk about, I'm sort of wrapping up this video, but I'm talking about the non-PD symptoms that PD causes. And so the medicines that you'll take that aren't necessarily as an anti-Parkinson's agent, but they're important to your quality of life because there's lots of little problems that Parkinson's can cause. And managing them and being active in managing them is very important to your quality of life. And so this is by far not an exhaustive list, but it's a start. And I mean, this whole thing, I mean, I've gone through a lot of medications, but this is not an exhaustive list. There are more out there. So, I mean, this is just one resource for you, but please talk to your neurologist and get every option and every single bit of education you can because it's important. But the first thing I'm going to talk about is muscle relaxants and Botox. So you can see I drew a little needle there because the Botox, they inject you with Botox. So I'll start with Botox. You probably know about Botox for, wrinkles in your face or on your frown lines. That's not how Botox started. Botox was initially developed as a treatment for dystonia and other muscle spasticity problems. And so if you have dystonia with your Parkinson's or other just muscle cramps in general, you'll probably be prescribed a muscle relaxant. A couple common ones, just to name a few, are baclofen, Flexeril, and Xanaflex. And these medications are important towards treating your spasticity, and they can dramatically make you a lot more comfortable, especially if you're having constant muscle cramps. So Botox injections are really good if your muscles are kind of stuck somewhere. So if you have a lot of twisting with your dystonia, or blepharospasms in your eyes, they can inject Botox straight into the muscle. Essentially what they do is they find an overactive muscle, a muscle that's pulling too hard, and they give you an injection of Botox, and it relaxes your muscle. And so that's definitely an important thing. The one limitation of Botox being that it takes a couple weeks for it to take effect, and then it wears off in 2 or 3 months, and you have to go back for more injections. So there'll be a slight period of time when your Botox isn't really working, which isn't the most fun. I've had Botox before, and yeah, that's part of the hard thing. The other thing they can do is give you a muscle relaxant through an intrathecal pump. that goes into your spinal cord if it's severe enough and it works well enough for you for that to be an effective thing. So it's called a baclofen pump. Piggybacking off muscle relaxants, I've got benzodiazepines. Benzodiazepines, or benzos, they're commonly called. You'll recognize them by a medicine that has the ending pam, the suffix pam. So you've got clonazepam, diazepam, lorazepam. Some other trade names are Ativan, Valium, and Klonopin. But anything in that PAM family is typically a benzodiazepine. They affect GABA receptors, which is an important part of Parkinson's brain chemistry. But these can be very sedative. Some of the shorter acting ones can leave you kind of feeling this ick of hungover feeling, and that's not so much pleasant if you take the shorter acting ones. The longer acting ones tend to not do that to you. These can be anti-anxiety medications. They can really help in that. Clonazepam in particular is commonly prescribed for Parkinson's for sleep. A lot of people with Parkinson's have REM sleep disorder or restless leg syndrome, and so that kind of keeps you up at night and it keeps you moving at night a little too much. And it can also have a muscle relaxing effect. So benzodiazepines can make life a lot more comfortable for you. The one thing is they are dangerous. You do have to be careful and be under very close care of a neurologist. And be very careful with them, particularly if you take opioids, because that can have a very dangerous sedative effect, which doesn't mean it can't be done. It just means it requires very careful management with your neurologist. And so if you take these, they're also very hard to come off of. So just, be forewarned, be educated. If you're getting on a benzo, just keep your doctor in the loop. And so the next thing that I really want to talk about to sort of end this whole, non-Parkinson's medication overview is talk about pain. Pain can be a very significant part of Parkinson's, and from personal experience, can be one of the hardest symptoms to treat and just one of the most life-limiting. So there's a couple different pain medications, and I highly, highly suggest that if you have a lot of pain with Parkinson's, going to see a specialized pain doctor who only does pain, who knows everything there is to know about pain medications, because that'll be really helpful. My pain doctor is amazing. And I couldn't recommend that enough. So the first line of pain drugs that you might experience would just be NSAIDs, non-steroidal anti-inflammatory drugs. So, that's like your Tylenol, your ibuprofen, naproxen, anything you can get, in that sort of area of the pharmacy is typically an NSAID. There's also, if you've heard of the medication Celebrex, it's something called the COX-2 inhibitor. It's sort of the newer class of prescription NSAIDs. So those are low level. And I also want to kind of go into this whole thing about the fact that not all opioids are scary, beside, other than the fact they're given this very scary title. I was actually on an opioid medication since I was 15, and I had no clue it was even an opioid. I was on the lowest level, which is something called tramadol. No one even told me that was an opioid medication. And it doesn't have too much effect. It's very, very safe, very low level of abuse, but it can relieve a lot of pain. But it has a very low level of abuse. Tramadol and Nicenta being the two that are considered very, very safe to use. And they can just dramatically change your life if you have moderate pain and you're living with it every day, and it can help so much. And so if necessary, some of the scarier name opioids, the bigger opioids like the oxycodone and the hydrocodone, those can help if you're being monitored very carefully by a doctor and you have a doctor that's committed to helping you work with them and live with them. Sometimes it is necessary, and sometimes it changes your life, because all of a sudden you're living in pain that you're rating a 6 or 7 or 8 every single day, and you're not having that anymore. It can be amazing. And there's other medications that affect some of your brain chemistry. So you've got Lyrica and gabapentin, which is they're both GABA analogs, and so those work to essentially increase some of the chemicals in your brain that make life less painful. I'm not going to go super into the chemistry of that, but those are non-opioid medications that affect your brain chemistry that can really help. Same with Cymbalta, something called an SNRI, serotonin norepinephrine reuptake inhibitor. So it increases the amount of serotonin norepinephrine in your body. And so those can be important. They're an important part of medication management, and they're something that you should definitely look into. My last kind of little point here is medicines you cannot take with Parkinson's. It's very, very, very important to know these medications. I cannot stress that enough. I cannot tell you how many times I've been in the ER and doctors have tried to give me Reglan. Reglan can kill you if you have Parkinson's. I'm not kidding. It's, it's an anti-nausea, particularly it's a gastroparesis medicine, which I have. But it's very dangerous because it can block dopamine in your brain. So there's a couple medications that affect dopamine, and that you can really not take if you have Parkinson's. Like it's very important to know. So Reglan, Compazine, Phenergan, and Doperidol are all anti-nauseas. Don't take that. Take Zofran. There's a couple of other anti-nauseas. If in doubt, have your doctor ask the pharmacist they're getting it from, if it affects dopamine and if it affects Parkinson's. The pharmacist will know that. Not all doctors, especially like in the ER, will know that, but it's very important to not let them give that to you. Most antipsychotics are also not okay. There's a couple of antipsychotics that are approved. Seroquel and Clorazil are the two antipsychotics that are considered okay for Parkinson's. All the others have really bad effects on Parkinson's, so don't take them if you have that. And if your psychosis is particularly Parkinson's psychosis, talk about Newplaza, which I mentioned earlier, as the alternative. And the last medicine that I want to mention here is something called amoxapine, which is an antidepressant. There's lots of antidepressants that are safe, and lots of people with Parkinson's end up on antidepressants because depression is a fairly common effect of Parkinson's. Prilosec, there's tons of antidepressants that are okay. That one amoxapine is the one that is not okay. So just don't take that one. Okay. Well, that's sort of the end of my little series here. Thank you so much for watching. I hope that you found that helpful and informative in some way. And I'll see you next time on Parkinson's 101.